All right, and then I was really happy to see our next speaker, T.Morneault, on our schedule. It ties in super well with what Dr. Henley was speaking about. I've known Teresa for a long time. She comes to us today from Augusta University. She has done a long stint in the Athens, Georgia area where I did become familiar with her. And not only is she awesome with respect to pelvic floor, physical therapy, but she's been my go-to person for any kind of sex therapy or counseling. I always call her. I have lots of little pieces of paper in my files of names that she's given me through the years. So without ado, Teresa, please come join us for your wonderful presentation.
Hi, thank you guys so much for having me. Before I even start my lecture, there were things I thought about after the fact, speaking of resources. So, and these are random. So skin issues, if you're stumped, Jody Gans is a vulvar dermatologist. She was voted top doctor in Atlanta Magazine, and she's at LolanskiDermatology.com. In regard to DEXA scans, there's a potential shift to include the forearm of the non-dominant arm, because a lot of people go to left hip replacement or fracture, and then you lose your baseline. And the forearm can also pick up parathyroid issues before the blood work indicates it. And that's a personal issue for me, which is I'm going into surgery next week. And so that point is near and dear to my heart. In regard to pelvic health therapists, referrers beware. There's a huge variety and quality. A lot of people, just like it was mentioned yesterday, a lot of young grads know the book knowledge. They don't know the art of it. It's a cash cow. You can pretty much bet that when students are coming through, easily there's 10% of them that say, I'm going into pelvic health, because it's a very great career for someone who wants to work part-time, because everybody wants a pelvic health therapist. And it's like, oh, I'll work 4 hours a week. Okay, we'll take you. And so it's not always the most trained person. They need to have a really strong background in ortho or neuro. We have direct access in Georgia with provisions. We can see 21 days or for 8 visits before needing a referral. I am a dry needler. I'll talk about that a little bit. You always have to have a referring provider for that. Our referral sources are physicians, dentists, and PAs. This does not include nurse practitioners from a legal standpoint, but there just has to be a doctor behind it. I do not call myself doctor, even though I have a clinical doctorate. If you find a PT that does that, it might be a little caution flag, because again, I think we have to remember the hierarchy, and the patients spend a lot of time with us. And so sometimes it's like, hey, ask your physician this or whatever. And the person goes back and says, Dr. Teresa said that you should do this. And so it's very helpful when I know my referral sources, because they would know I don't roll that way. Let's see, mental health, it's so huge in my practice. I always love when they're seeing a mental health therapist, because again, it is a fine line. You get to know these people so well, and they tell you their secrets, because you're spending an hour with them over weeks, and you know so much more than many of their family members or their partners. Body Keeps the Score. Brain, Mind, and Body and the Healing of Trauma is a huge book in regard to that. I generally look at the pelvic floor at visit 5 because I think you'll see why today, but you've got to look at the whole body. And then this could have also been titled Love Your Pelvic Floor, because I want to change the story. You know, like there's so much shame, or we can feel like our pelvic floor has failed us. But when you look at how people are living in their bodies, you're like, oh, pelvic floor is doing the best it can do for me. Let's see. And then my goal is generally to be done at 6 to 8 visits. That's very different from my early Athens days. And generally no more than 12. And a lot of times I'll write the order for 6 months because sometimes people want to check in with you, and it's almost easier to discharge them if you're like, hey, you can come back, like just give me a call, versus them feeling like that's the end. Dr. Henley talked about so much of this anatomy, but just remember pelvic floor nerves are S2 through 4. The root of these nerves begin at L1. And so the back matters. That's why you need a good orthotherapist. Innervation of the foot or the lower leg, L4, 5, S1, 2, 3. Again, the nerves matter. The health of the back matters so much. And that may be all I have in regard to that. Okay. So holistic approach to pelvic health, a PT perspective. Objectives. Again, just a broad understanding. So again, I hope everybody leaves here with something that you can do for yourself, or your partner, or to tell your kids, because this is how to live in our bodies. So Dr. Yonda, the picture to the left, I actually did not know his work. We were taught about him in school, but in the work and how I've evolved in my practice, he's just a wonderful man who was really kind of ahead of his time. Again, that quote, he probably said that in 1970. And I mean, think about the 70s versus now, and it's like, it's just more relevant now. This person, when you're thinking pelvic floor, look what she's doing at her ankles. Look how her knees are backwards. Her pelvis is forward. Her butt is tucked. Think about your parasympathetic and how that would be affected. And then sympathetic being at that thoracic lumbar level and how that would be affected. Additionally, her abdomen is out. And so it's a little bit different when you have somebody who has had children. But think about all the middle schoolers, all the high school kids, all the college kids who are really slender, but they have that little pooch. And they're like, oh, my family's always had this pooch. They are not in their core correctly, and it will probably haunt them in the years to come. We'll talk about it. So the anatomy, the goal is rib over pelvis. So it matters for so many reasons. It matters for good ability to control emotion. It matters for good digestion. It matters for how much pressure goes into that pelvic floor. It matters for pain. To the right, that's not what I wanted to do. The true core muscles, diaphragm is the roof, pelvic floor is the basement, the transverse abdominis, not your six-pack, is the abdominal muscle, and multifidi is on the back. We will not talk about multifidi today. So anatomical effects. Think about the tailbone. So first of all, how many people have fallen on their tailbones? How many people have scoliosis, whether it's structural or whether it's functional? So very often in today's society, it is functional on top of structural. And so to differentiate that is, the functional one, we've created it. So I tend to treat and write my notes in a left pelvic shift with my trunk facing right. And so I have a right leg that's a tiny bit longer. So I have created quite a difference for myself. Labral tears. So when you're thinking groin pain, when you're thinking hamstring tendinopathy, Again, this all goes back to having a really good history. So when I take my histories, the first visit, it's 45 minutes easily out of my hour. Sometimes it's the hour. But labral tears, research is showing they don't need to go to surgery, but they do need to go to a pelvic health therapist or someone who knows how to get them out of their pelvis and get the pressure off that labral tear. And then pregnancy, the amount of pressure that goes into the pelvic floor, the stretch on the nerves during delivery or with a C-section, the pressure on the back. And again, think about the person in the first slide, how she was already thrown forward into that lordosis and that abdomen not really being in control. And then you put a pregnancy on it and you're easily looking at SI joint pain, prolapse, and some other things. Anatomical effects, so diastasis or diastasis recti. So within our world, the research is showing it does not really matter like what your width is, it matters about the depth. And so that's kind of changing. Research also shows that if you have greater than 2 finger, that the person needs to go to a surgeon and have that corrected. I'm just going to say I can correct them. Because it's all about strategy. You've got to get that breath in that pelvic floor. You've got to get that transverse in. And then you're going to find that without that pressure on the rectus abdominis, that it will come back together. So from a pelvic health standpoint or from a prolapse standpoint, so again, just keep thinking about that first person. But, so first layer, third layer, here's third layer, here's obturator internus, here's piriformis, there's coccygeus. I call the coccygeus the dogtail muscle because if the dog is in trouble or if there's a thunderstorm, they're typically tucked. Look at your patients, they are tucking. They're typically slouching into a posterior pelvic tilt and sitting, but then they are kind of tucking under when they stand. So. When I'll talk about Kegel a little bit more, but another nugget to take away is you typically do not want people doing more Kegels, or you want to define it in a very different way. So when someone is typically doing a pelvic floor activation, you will see them, they'll pull in on their adductors, they'll hold their breath, and they'll kind of pull their belly in. Although some of them are just like, okay, I did it. Most hold their breath. But you should not see any action. But the bigger piece is, I don't care about the grade of the levator. So I really don't grade a pelvic floor. And so again, I'm not basing that off research. This is the Teresa way of doing it. But I care more about that first layer being part of the conversation. And when you have someone going into that deep layer, you're missing the key points of the pubic symphysis, the tailbone, and the pubic symphysis. So, again, I'll let you guys read the stuff to the right. But typically, it's like, okay, levator ani issues. Well, in theory, that should be the levator ani issues. But the truth is, like right there, I kind of covered it. That's your obturator. You've got a coccygeus in there. You've got a piriformis in there. If those regions are squeezing, again, we're back to that first picture. Levator ani is just in the mix of it. And so to me, I do not feel like you can get a true strength test on a levator because everything else is combined in it. Also, they typically show weak, but they're showing weak because they're too tight. So if you've got someone who is totally pulled in on themselves, then the issue is they need to open that region up so then they can ultimately pull power in it. And a big piece is they need to get into their glute max. We'll talk about a little bit. External anal sphincter, again, that's what people are going to complain of. So this is the first layer I was talking about. So I describe this as it's like the spider web in the barn. Typically that spider knows where to put that web, and it can withstand some wind and some other stuff. So if you can pull these tiny little muscles into the conversation, then that sets the tone for how the diaphragm and the pelvic floor can talk to each other. So again, here's a biggie. Another take home is when you're trying to check your patients for hypertonicity, you can typically, and this is another way when there's a wait list to get in to see a pelvic health therapist, you can tell them, typically if you feel one side or the other, one side's going to have a nice spring to it, the other side's going to be hard as a rock. And so just tell them in the shower to massage that region. And that will take them so far in regard to pain with sex and how much pressure they're putting on that bladder. So again, you can read the thing that comes to light is pain with orgasm for me, or clitoral pain. So I'm going to show a picture later, but when you think about where that clitoral region is, it starts here, but then it goes right there. And so Andrew Goldstein is very big in the PT world, and he's a doc out of, I think, Boston and DC. And he says that physical therapists own the clitoral region because most gynecologists don't check. But if you pull that region back and you want to feel for a good slide on that hood, just like you would want to see or feel that on an uncircumcised male. And it's unbelievable, like how many, sometimes you'll pull back on that hood and you'll just see a white ring where there is so much restriction. So please just make sure you're checking that area. And again, it's so helpful to patients to know this because all they have to do is just kind of, this is really hard to do, I'm just going to say. Anyway, all they have to do is just kind of put one hand here to stabilize, and then they just do tiny pulling here. And then you'll just, within 30 seconds, and I tend to show people with mirrors, you'll start to see that hood, you'll start to see better color. And so that's, again, just two quick things you guys can do in the office. The other thing that I'll just randomly say, otherwise I'll forget it, but the thing that I find is most people clean too much. They consider the area dirty. And so, if they come in with skin issues and I'm like, hey, do you by chance, how do you clean this region? And some literally use loofah stuff, and it's like, oh, don't. And so then explaining the Hart's line and how that is endoderm, but just patient education and telling them to keep that outside region. If they use lotion here, they're going to be dry there. And so just to shift that, I generally say coconut oil on that outside labia minora to the groin, then that just keeps their skin healthier. Glute max. So if you are not living in your glute, how do you get in your glute? You don't squeeze it. And we have been told to pull our belly buttons back to our spines. We have been told to squeeze our butts and to do a finish if we're lifting. And on your patients, you want to see some depth here. And if you don't, they are living inside their pelvis. And that is just good. And so if you think about that posterior line from their tailbone to their sits bones, then they're just living too tight in their pelvic floor. They are pushing on prolapse surgeries, or they're pushing on a prolapse that is there, potentially making it worse, particularly if they're trying to lose weight and they're exercising and doing it wrong. But again, here's just a picture. If all that is coming in, we just don't have the muscle structure there, and it's going to fail. Mechanical dysfunction, so she's peeing. So this is a really old study, but pelvic health therapists were so excited when this study came out. So society wants this, but if you see somebody's belly button going in and down, they're loading their back. They're loading their spine. She's cutting herself in half. So you want to see a diaphragm, talk to a pelvic floor, talk to a transverse abdominis, because that's your canister and that's your baseline. The true core muscles are anticipatory. If you think about going to the store and you're like, hey, and I have to watch my time, and you're like, hey, I'll grab the milk, and it happens to be in a paper bag or your recycle bags. People, and then it's the potato chips. You're going to see somebody kind of overdo it, but then they correct. It's because the true core muscles, they're like, oh, she's about to reach into the cabinet and pull down something heavy. So and a lot of people have just knocked them out. Like, they don't know about them, they've forgotten, we were really never taught. But you want to get back to that true dynamic, and then you can have your six-pack for sure. More mechanical dysfunction. So our heads typically weigh 10 to 12 pounds. Think about texting or surgery, or just examining patients. By the time your head is at 30 degrees, your head weighs 40 pounds. By the time you're at a 60 degree, your head weighs a relative 60 pounds to the rest of your body. So we put a lot of load on this. So again, a great study, just in all the dysfunction. Again, within my histories, by the way, I tend to take pictures and videos on patients' phones so that they can see what their movement dysfunction is. But I'm very wary of that, or avoid it altogether if there's an eating disorder. I mean, you can ask someone how, I learned this from my UGA days, you can ask someone how much they drink, like how much water, and you can trigger them into eating disorder. It was really fun working with that group at UGA. Here, again, look at her belly. So she's already, her baseline is, her home is too tight. That's a relatively light weight. And she's just pulling everything down into that pelvic floor. Or if someone tells me, like, oh, I exercise with my dog, it's like, okay, well, does your dog pull? Because that's kind of a recipe for disaster, because this person's in their knees. They're not in their hips, and they're not in their core. And then here just shows you. So typically it's a typical posture I would see. So when I see that, I'm not like, okay, well, pull your pelvis back, pull your shoulders forward. The changes that we make are by manual release, visceral release, and then teaching people how to get into their bodies. Psychosocial, again, a lot of times it's like, don't talk politics or religion. It's the elephant in the room. You know, I mean, so many people need to value what they have, but they need to break away and find their own truth. And so that's why I like the mental health therapist, one of the reasons. Again, with this slide, it's like, is your patient in that sandwich generation? Are they dealing with kids? Are they dealing with their parents? And I am in that generation. Do they have pets? Do they have a farm? It's like, oh, you're going to do surgery on somebody. Well, they have to pick up hay. And so it's really knowing your patient's history. I love the Peace Center at Greenville. These are actually my kids who are now 19 and 21. But again, like, do you have young kids? Are you running them everywhere? And how do you make all this work? I love this picture because she is taking up space. This person is not. I mean, if you look, she's really squeezed, and certainly she's slender, but she's too narrow there. She's too much in her lumbosacral, she's too much in thoracic. It's affecting the way she can lift her arms. So those are the things I look for just while I'm talking to people. So again, I'll let you guys read most of this, but What Happened to You is a book that was written by Oprah Winfrey and Bruce Perry, who is a psychiatrist. And instead of saying what's wrong with you, it's like what happened to you. And again, this is such a telling slide. Very sad. Okay, so how do we do this? So core training focuses on restoring timing and sequencing of the deep muscles. They're anticipatory. So the problem with what I do is there's not a lot of research. Within pelvic or within physical therapy, we are trained to strengthen. And so Dr. Yonda spent very little time on strengthening. He felt the deal was balance and function. So he had polio when he was 15. He was a quadriplegic. He ultimately did learn to walk, but in his later years, he had post-polio syndrome. And so he did lose the ability to walk, but he lived it. And that's the way I approach it. It is not about strength. It is about getting your fascia to work like your glue and let your body be its amazing self. Diaphragmatic breathing, that is where I start. So typically it's like, hey, well, most people are chest breathers. Some people will breathe down into their lower abdomen. And if you ask somebody, can you yoga breathe? Can you belly breathe? Sometimes you'll see them like pull that abdomen out. And that is a lot of how it's taught in physical therapy. I don't teach it that way. So think of this diaphragm as like an umbrella, or I often describe a jellyfish. So a jellyfish domes, and then it flattens, then it domes. And so breath should be like the ease of a jellyfish. A jellyfish does not get in a hurry. It covers great territory. And so that's part of cueing them to get into parasympathetic. So this is typically where I start. So when someone inhales, it's just a matter of gently filling their lungs and then getting that diaphragm to flatten, and then it needs to talk to the rest of the core. So it's another way to get a big cell in pelvic PT, because ultimately I want that person to feel that breath in their labia or in their testicles or in their anus, and you can generally get it first treatment. And it's just astounding for people. And so then you've set the tone for, it's like, okay, this is how you have to live. Your secret is in your or your strength is in your softness. So child's pose is a great place to get it because you're kind of shutting down that anterior region, and you're really getting it to drive down the back. And so a lot of times when I cure, drive it down the back and let it fall off the tailbone. So that's the beginning of your piston effect for great lymphatic cleansing, or again, decreasing anxiety and doing a lot of other good stuff.
I'm gonna put this on you because people online.
Oh my gosh, I'm so sorry.
They can't hear you.
I'm so sorry. I'm so sorry.
I'm working on a doctor.
You're funny. Guys, I'm so sorry. Oh, I can hold it. Okay.
Thank you.
Oh yeah, so sorry. Okay. Okay, so abdominals. Again, a lot of people are really after that six-pack. It's not my favorite thing because, again, I think we're trying too hard to look good or be good or whatever. We need to take up space. But you'll typically find it's the six-pack and it's the external oblique. And that goes into poor opening through the rib cage, dropping of that diaphragm. And so that's another reason why I start with diaphragm. So it's really this muscle that I care about. From the backside, I don't care so much about the superficial muscles. That's where they're living. I basically have to get them out of it. And I often can do it without dry needle. But if you have to go there, it can be really helpful. And oddly enough, within the acupuncture world, the going down the spine, paraspinals, That is the bladder line within Eastern medicine. And so that would be another reason, even though, so dry needle is we're going after muscle. We are not acupuncturists, but I have a lot of acupuncture friends, and so they kind of tell me stuff. That goes back to the tibial nerve as well. But anyway, the muscle I care about here is multifidi. And basically, multifidi, it starts right at the sacrum, and it attaches, and then it literally like fingers up all the way to the neck, and so it decompresses you. And so, but again, that can be a tough one to get, and I generally do that at 4th visit because that can be very frustrating for patients. Okay, so back to Dr. Yonda. A muscle can be as strong as possible, but if you don't fire it at the right time, the pelvic chain is the key to most musculoskeletal dysfunction. And you just have to think of it as that's our crossroads. So just back to, this is the big piece of what I care about. Not so much that, other than the fact that I want to get them in their glutes and away from so much pressure inside that pelvic floor. So I'll go ahead and say this in case it's not at a later slide because I can't remember. But when I ask for a pelvic floor contraction, and certainly I care what their baseline is first, but I cue from pick up a jelly bean at your labia. For a male, it's like pick up your testicles. And so, but the jelly beans at the labia, again, it's a great icebreaker. And I am not looking at their pelvic floor, by the way. I'm doing this just cueing them through it because I'm going to get to that pelvic floor later. And that gives them a chance versus stage fright when I'm staring at it. And then pick up a jelly bean at your anus. And so I cue that based on like, okay, this is like holding a child's hand, or it's like holding a cat. You cannot squeeze the cat. You cannot dangle the cat. Like there needs to be an integrity to this system as to how it all comes in. So a lot of times people have no idea how to do the front part and they overdo the back part. So, but the real key is you want them to be able to do a reverse Kegel or an eccentric contraction on their pelvic floor. So I cue them to blow bubbles from their vaginal orifice or from their anus. I tell them I don't care if they pass gas, but they typically don't. And then ultimately, I'm like, spread your sits bones. When I go to the pelvic floor at the 5th visit and I'm checking vaginally, I'll say create space around my finger. But they have to be able to descend. This can be particularly important for people delivering because I think you would agree a lot of people don't know how to push. So if you can get that baseline, you're going to find a lot of issues resolved. If you can get them in more of a resting space, and again, it's so counterintuitive for people who are so afraid that a prolapse is going to fail or they're trying to avoid surgery. So, the clitoris. Little hood, but then the way that it extends. So, a lot of times people who are unable to achieve orgasm, it is because, again, they're just kind of bound up in the fascia right there. So, just having them, even if you keep the labia closed and you just work across it, or if you go here, and I love to have partners come in, and that would be, I mean, at UGA, I didn't care if the boyfriend, the girlfriend, I didn't care. I just, I want these people to learn anatomy. So putting your fingers under there can really open up that whole region. And again, this is something they could do at home before. down-trained coordinator said, this is where I talk about it. It's like, I want, we have great pictures so that people know what we're actually doing and what we're going for. And so that's the obturator. And then there's coccygeus, and then there's piriformis. And so again, if those muscles are bound, if they're squeezing their butt, you're not gonna get where you want. And that's what a lot of pelvic health therapists do not understand. They're literally just going straight to that pelvic floor with e-stim or biofeedback. I don't use e-stim or biofeedback other than my hands because I don't want to get them dependent on it. And people get obsessed about the numbers. Here's other interventions we do. So we teach scar massage. This is visceral massage. So that's one of the first things I do. And again, it makes people really happy because it releases serotonin. They can carry that through with their partner, or they can take a ball and roll their belly. It's incredible for constipation. It's incredible for pulling that bladder off that pubic symphysis. The coccyx mobe, I tend to not go to that too quickly, but and even with males, like again, I spend so much time external, but if somebody has a hip issue or a back issue and they're just not getting where they need to be, it is typically because their coccyx is deviated and rotated. And so it was actually really fun to treat at UGA. The males were amazing because if they had erectile dysfunction, if they had pain or constipation, they came in and they were ready. They were like, you do whatever you need to do. And so a lot of times it's the females that need a little bit more convincing. Dry needle, that just shows a little bit of that. And I do, I tend to not, we can dry needle the pelvic floor, but again, that can be hard to convince somebody. But I do dry needle obturator and coccygeus a good bit. And then I cannot say how much I love feet, because innervation of feet, it's coming off sciatic. And many of us do. We lock out or we hyperextend. If you think of a male that does not have a butt, that male is in their hamstring and hip external rotators. They are not in their glutes. You've got to open up the foot because over time they've jammed their tibia and fibula. And so just like you need rotation through the radius and the ulna, you need to have motion in that tibia and fibula, and it will typically take care of a lot of plantar fasciitis. It'll take care of a lot of knee pain. So all of this is done, not the dry needle, but the visceral, the working on the feet, that's done before I would go to the pelvic floor. Unless the patient's like, please just look at my pelvic floor because I'm worried about it. So resources, again, the secret is in the softness. Strength is in your softness. That's a big thing that I always say to people. The myofascial stuff, a lot of times people come and they're like, oh, I told my friends I was going for my massage today. And I'm like, don't say that, because it is different. But I tend to work on the belly. And then the next time I work on the posterior leg. Then the next time I work on anterior leg, and then I work on lower leg. And I do all of that before I go to the pelvis. And then you're teaching them core in the midst of doing that. And everything just typically, particularly if you can see them one time per week for 6 weeks, a lot of times you're done. If you have, like, if I have issues, if they have issues, if it ends up stretching over time, it's often going to go to 12 visits because they're like, it's not getting better, it's not making sense, and they end up really confused. I rehab via Pilates. I'm very grateful that Augusta let me bring my Pilates equipment there, because that is a way to break into a system where when they're on the Pilates reformer and they move out, and I'm sorry, I don't have a picture of it, but if they push out, they've done a squat. They've just done it anti-gravity. And so you can wrap a TheraBand around somebody and tell them to float out their lateral thigh. And it's like, well, wait, what's moving it? It's your glute. So we should not drive from our knees. Again, I'm huge on people getting massage and rolfing and acupuncture and chiropractic. Again, you want people to have good providers, but it takes a village. I did not bring dilators, but Berman dilators are my favorite because they're silicone, they're hard, but they have a vibration component to them. That said, so they were created by Laura Berman. Sadly, she sold out to Naughty Kitty Cat. So just 2 weeks ago, I was telling somebody, like, you've got to get these burned. She's like, I can't find them. It was a doctor's wife, thank goodness. And so I was like, I think I have an extra set at home. Let me pull them in. And she's looking, and she's like, it's Naughty Kitty Cat. And so I don't know what I'm going to do with that information, but they are great dilators. There's 4 different sizes. And it can help with massage to open up the external region, the clitoral region. And then mental health counseling, I really cannot say enough. So hydrate, we say 1/2 ounce per pound of body weight, and more for exercising or hot weather. We certainly would change that if someone else has told them something different. Typically urination every 2 to 8 hours with at least an 8-second void. That lets you know you're really using the bladder. Defecation ranges 3 times per day to 3 times per week. The worst case I ever saw was 1 time per month, and the person had a really great outcome. Because again, that is space occupying. They are going to have issues with everything else. And I was actually just called to, again, a couple of weeks ago, and somebody said, the physician says you're my last hope. I poop 1 time every 2 to 3 months. And if you can't help me, I have to go to surgery. And I was like, I can't. Well, I could. I was like, whew, I can't because I'm out until October. But at the same time, it was like, gosh, could I have? Again, I would have never thought I could help 1 time per month. It was pretty rewarding, one of my favorite cases ever. Get adequate sleep, relax, meditate. Other stuff, you can do your own visceral massage. Again, you can get a softball and rub your belly. This stuff is great for little babies. Splinting is a big thing we talk about. And again, I often find external is a little bit better than internal. Pessaries, I don't do pessaries, but I like that my group does. I didn't deal with that many pessaries in Athens. Squatty potty. Do you guys know about squatty potty? Yeah. So squatty potty is, you should Google the YouTube video. But what you're doing, if you have your knees higher than your hips, you're opening puborectalis, and so you're giving the body a biomechanical advantage to get that stool out. They did a great ad because when I was at UGA, all the fraternities knew about it. Like they had squatty potties because, males are fun to treat. They really are. Pelvic wand, that's more specific trigger point release. So core stability is the ability to control the position and the motion of the trunk over the pelvis so that we can produce, so that we can transfer. I love these slides, but when I was looking at that one, you can't see it. When I see it on my slide, she's kicking her foot weird. But again, like look at the lightness. And so she's driving her psoas iliacus perfectly. She is not driving from her knee. And that's key for joint health. Resources. My slides were off of pelvicguru.com. It is a great resource. They try to pull physicians, any kind of health provider together. They have great education, handouts for people. Again, those are my major handouts. They have one called How to Treat a Pelvic Health Therapist. I meant to include it for you guys, but I didn't. Neri Clemens is a PT out of Oregon, has Meditations for Pelvic Health, which is amazing because she has loving kindness on it. She has breath work. She has thinking about your pain. What color is it? What shape is it? It's taken me out of a headache. Pelvic trigger point tools, again, Intimate Rose is probably my favorite, and there's just a lot of options with that. By the way, I apologize that some of the slides didn't have the resources. If you guys want them, I pulled from various things. Okay, I have 6 minutes, so I'm going to do my extra slides for answering questions in a different way. So here is the glute. That's what we want. If you have someone who works from their knees, so think about when you sit to stand, if you use your knees, and most people do, or if you stand in your knees versus being soft in your hip, you're living in your hamstrings. There are 3 of them. If they're separated out, 2 of them basically do not touch the femur until it's at the knee and then up here at the ischial tube. And so that would have no power, except it's really going to torque your hip. And again, create a lot of pain, create a lot of dysfunction. And it's very hard on the knee. So, and then one hooks halfway. And then, but still, what's missing? Your glute. And so if you're driving backwards, you're torquing your hip, and then you're creating chaos in your spine and your pelvis and everywhere else. Additionally, sciatic nerve runs through piriformis and obturator. So how do you alleviate that? You don't squeeze your butt. Easier said than done, but it really is, it's worth knowing. So if you guys catch me, I'm happy to try to get you into that glute. Hip flexors. Again, we're taught like to drive from our quads and hamstrings. So here is one quad. This quad hooks from the knee. It goes up. It hooks at the AIIS, which means it's right at the hip joint. If you activate from there, you're going to knock out your psoas and iliacus, and then they're going to react. So if you see somebody do a straight leg raise and they tilt their spine, then you know they're not driving proximal to distal. And again, that wreaks havoc on a pelvic floor. I love this picture because psoas comes off of T12L1, diaphragm is at T12L1. And so again, the song is correct. We are so connected. Again, that's quadratus, iliacus, glute med. Again, if glute max is inhibited at its insertion, a lot of times glute med is as well. And so this is why I do a lot of visceral work, because all of this, if they're driving from quad, all of this is going to be locked in. And I have to release it in order to get them to drive correctly. And then there's pelvic floor. I think that's it. And I don't think I even said thank you or I give my sources or anything. So, yeah. Ooh, 3 minutes to spare. My apologies that I didn't have this on.
Thanks, Teresa. Questions? We'll start with Dr. Perry.
Just real quick, number one, thank you so much. I love body work. I got the opportunity to work with Teresa for years and years. The tightest pelvises in the world reside at a college. I would tell you that. It's impressive when you find one that's easy to get into. I'm like, what makes you like this? Because you're so different. Right. We will get all of Teresa's resources. We'll get lists together and make that available to everybody. The dilators truly are, the Berman dilators are about $35 last time I looked for a set of 3, easy to keep clean, easy to use. So the naughty kitty cat, I promise you, is not going to be a problem. But and I would love more on, because the wait time to get into y'all is often extended. So any type of reference material you could give us that we can do place holding and start off with the elementary kindergarten type of therapy, we would love.
Yeah. And I would just point back to Pelvic Guru. You're not supposed to use it if you're not a member, but I think they have 4 handout, maybe 3 handouts on dilator use. They have 1 handout on the wands. They have incredible handouts on the squatty potty and other stuff like that. 4 pages on constipation. They're invaluable. Absolutely. They've changed the game for me. So I would encourage that a lot.
Right, next question.
Hi, great talk. Questions for childbirth and second stage of labor, reducing risk of all that. Do you have, I know we have changing of, you can push for this amount of time. Do you all have any suggestions from your side as far as even the use of vacuums, the use of forceps, all these, what can we do as obstetricians during the labor process, the inducing labor, big babies, all of this, it has an effect to it. So I just want to know if you had any conversation about that.
Yeah, so I'd love to see prenatal. I typically don't see it unless they're having an issue. I had 2 cases recently that they couldn't stay out of the ER, and so they sent them to me, and again, got them out of the glute because they were just driving their sciatic nerve crazy. Just FYI, the newer PTs do internal on pregnant people, which horrifies me because it's like, I'm good enough to do it external. Why would you go internal? And so just know that if you need to know your pelvic PT, and there needs to be a conversation. And again, I cannot say enough about Dr. Klein and Dr. Perry, who particularly, I cannot remember your triage nurse. What was her name?
We have Candy right now.
No. It was somebody.
Fran.
Fran. Fran, I mean, I cannot tell you the times that I called Fran, and I was like, will you ask Dr. Klein, because I had her cell number, but you don't want to take advantage. But I was like, Fran, will you ask her, can I do this? And it wasn't even necessarily about her patients. The thing I would say is they need to know how to get into their bodies. They need to expand that rib cage. They need to know how to drop that pelvic floor and have integrity on how they wrap that transverse around. So again, transverse, a quick cue on transverse. Do we have time for that? Sure. Okay, so instead of pulling your belly button back to your spine, if you think your belly button is right here, it always was, if you gently pull it 1 millimeter back towards your sacrum, you should feel like a little smiley face across your lower abdomen. That's your transverse. Pelvic floor, if you ask for those jelly beans, you can feel it. Same thing, medial ASIS. It is unbelievable that you're asking for such a lot of times I'm like 1%, and you just feel it fascially travel. So I would just say get them in their bodies well, and again, I love massage and all that.
Go back to this microphone.
Okay.
Hi, I'm Janice Presley, a gynecologist in Snellville. Do you have any advice for finding a good pelvic floor physical therapist or someone in the Atlanta area you'd recommend?
So Beth Kemper's my favorite. Lona Howell's my favorite in Athens. Nidhi Patel is at UGA, and I mentored her, and she's a really strong ortho as well. Kelly Poole is another one in Athens. I know more that I don't like than actually that I like. But typically, if you look for WCS or PRPC, then you know that people are certified, or if you look for someone who's older. It's like I've been in this 25 years, and a lot of my knowledge is because I've had injuries and I've had surgeries. Dr. Perry found my breast cancer. Bilateral mastectomy, I was stage 0 because it was caught so early. And so it's like, I know what it feels like, to have rigidity there. So I would look for those. And then, other than that, there's a Pelvic Guru, Herman and Wallace, and APTA. They have sites and directories, and then you can get more info. You're welcome to call me, and I'll try to help you. Like I can put it on my form, like, hey, anybody in this area. So.
Next question.
Thank you so much. Are there certain exercises or exercise programs outside of the PT realm that you definitely tell patients to avoid or to do? So, for example, you were talking about tucking being so bad, and there's bar class. It's like all about tucking. And I find that the people who do bar regularly have super tight pelvic floors. So is there anything in particular that you tell people to avoid or to do?
The big thing I say is just try. You want to see this region round out. And I've done bar a little bit. I think what they mean when they say tuck, they're really talking about pulling the integrity together. And so they don't really want the actual tuck, but it's semantics and you're teaching a whole class. And so I'm just big on saying, like, that region, there's no reason to narrow it. You know, like, we need our diaphragm talking, so nothing should really pull in and narrow. Mutu, you know, I think all of those can be good. You know, I'm not a huge CrossFit person. I've seen people who have prolapse and diastasis who've never had kids, and it was because of CrossFit. But again, educate a CrossFitter and get them out of that competition mode. They do incredible, you know. So you want that motivated person. We just need to educate, and we really need to be educating in middle school, because I do treat a lot of middle schoolers playing soccer who leak urine. So. I hope that helps.
Hi, Christina Elstad. I'm from Athens. I just have had several patients asking me recently about the little home devices. LV is one of them, these like pelvic floor trainers that people do on their own time. Do you have any experience as to whether or not those are helpful for people or mislead people?
You know, I think the biggest thing is compliance. I'd rather see them do it at home than spend money actually within a clinic. But I just want them to learn that the whole system matters. And to me, you're not going to have a healthy pelvis if you do not have a healthy diaphragm. But someone called me recently and she was just like, well, it helped my friend and I want to do it. And I'm literally in Augusta. I'm like, if you want the equipment, like, this is my biofeedback. You know, and so I'm not too huge on them. But again, historically, I did work with that stuff. But it's kind of cool. Again, it's some competition for PTs to really up their game on, like, but that's what that can offer you, and this is what I can. Yeah.
Hey, Tony?
Yes, thank you very much. I don't have any personal experience with a lot of this, but every time I heard about guys and ED, I did perk up a bit. So a few years ago, I started having excruciating back pain, and I'm sitting there in front of the computer doing ultrasound reports about 10 hours a day. And so I purchased a Varidesk. So I started standing up for 12 hours a day, and I'd get home sometimes and say, you know, my feet really hurt, and I have not sat down one time in 12 hours. So now I need to dial that back a little bit. Do you have a specific chair or manufacturer that kind of is the best of the worst?
So I think the main thing is we need to move around. I mean, typically move 10 minutes every hour. If you are using a standing desk, again, you just don't want to be in that locked position. Typically, this holds for washing dishes too. If you put your foot on something, like one of your feet, and you can switch. But that generally throws you in a more neutral posture. And so that's a good idea. I don't have any specific chairs. Some people use the Swiss balls. And again, those can be amazing, but if you're there and your quads are totally activated and you're doing that all day, that'll mess up your psoas and iliacus. So I think the main thing for all of us is just move. So, sorry.
No, that works.
Yeah.
Thank you.
Kathy?
Cassie Campbell from Athens. And so,
hi.
yeah, so good to see you, and all the work that you do is amazing. We're sad to have you gone. But I'm curious, I had this internal cringe a little when you said don't tell them to do Kegels, because I don't know about you guys, I tell all my patients to do Kegels. So I'm curious on that. I mean, I know a lot of this is if it's dyspareunia or tightness or dysfunction with urinary or fecal issues. Is there a place, you know, for, say, these women that have that gaping introitus with prolapse and everything's falling out, and you tell them to Kegel and they Valsalva and nothing happens, and you're like, you don't even know what your pelvic floor muscles are. So is there a situation where a Kegel would be an appropriate intervention?
Okay, first of all, thank you for that question, because when I said the jelly beans, to me that's a Kegel, because it's a pelvic floor activation. But you're just changing where you're pulling it from. Mm-hmm. And so if you practice those jelly beans, then that's just going to take you to that second layer. And then hopefully you're in a good position on your trunk. Your trunk should feel like it's off the pelvis, and you should be in your glute, and so then everything has space. But 100%, I do want people to ultimately, I want to down train them first, but the jelly bean is the key. Thank you so much for that clarification. But it's just softer than what people are designed. And so what they read in the magazines, they just go for that deep because they think more is better. And it's just like, no, like drive it from that bottom, because you've got the key pieces from the pubic symphysis to the tailbone to those ischial tubes that should keep everybody nice and balanced. And then your engine, so again, to me, the anterior core is the engine, and I do describe it that way. Your breath is the fuel. Yeah, thank you. And I apologize this wasn't on.
Okay, Joy?
Thank you so much for your talk. I'm Joy Baker, General OBGyn in LaGrange, Georgia. I want to ask the question that patients ask all the time. What about these balls, weighted cones, all these things that are being marketed on social media that they're hearing about that are going to like boost their sex lives and make them, sex goddesses and all these sorts of things. How do you counsel your patients about these items?
So, again, some PTs are very into them. I am still, particularly if you have prolapse, it is such a humiliating, so I went to a course, I did not buy any, but we had to use the weights, and I had prolapse. I couldn't keep that in because my prolapse would push it out. So I'm all about, so I talk a lot about fascia, and I describe it, vegans and vegetarians, close your ears. I talk about chicken, the chicken skin slick part and the muscle. And it's like, that slick part is skin to muscle, muscle to muscle. It is everywhere. It is our glue. And we have glued ourselves into a mess. And so it's like, when you leave, I want you to take up space. Because then you really get, it doesn't matter as much. So think about Ehlers-Danlos. If you can get somebody to stay out of their joints and drive off this soft system, and then what glue they have is going to come together as a unit and they'll be open. So typically if you have people doing that, they're just squeezing really hard and they're locking down. And so I can typically talk people out of it. I do want to say one more thing though about, so a lot of times if patients are complaining that they push their partners out during sex, again, if they are orgasming, they are tightening down. They're using that levator ani. Path of least resistance is out. And so if you will cue them from drive that first layer first, and then it's like you're pulling your partner in, then that's going to keep them more open, and they tend to not do that. And that's the same with pushing a pessary out. Yeah.